Good afternoon and good morning to those folks we have from the West Coast. My name is Adriana Sakari from the National LGBT Health Education Center, a program of the Fenway Institute in Boston, Massachusetts. We're so excited to have all of you with us today for our webinar series on providing effective health care for LGBT people. Today's webinar is LGBTQ Youth, Providing Care, Protecting Confidentiality. The webinar will last 90 minutes. The presentation will last about 60 minutes, and after the presentation concludes, we'll have about 30 minutes for questions and answers. I'd like to take a moment to introduce our program, the National LGBT Health Education Center. The Education Center is a part of the Fenway Institute, the Research, Training, and Health Policy Division of Fenway Health, which is a federally qualified health center in Boston and one of the world's largest LGBT-focused health centers. Our mission is to provide educational programs, consulting, and resources to healthcare organizations to help optimize their ability to provide accessible, high-quality, and cost-effective care to LGBT people. If you haven't already done so, please join our mailing list so you can hear about future webinars, trainings, publications, and resources. You can sign up on our website. In a moment, I'll introduce our speaker, but before I do, I'll brief you on a few housekeeping points. Today's webinar is also sponsored by the School-Based Health Alliance. SBHA's mission is to improve the health status of children and youth by advancing and advocating for school-based health care. SBHA provides the school-based healthcare field with help, high-quality resources, training, information, and guidance, as well as motivation and inspiration to achieve excellence in their work. For more information, you can visit their website at www.sbh4a.org. We are offering continuing medical education credit through the American Academy of Family Physicians for this webinar. Credits are equivalent to AMA Category 1 CME credits, which are largely accepted as CEU credits as well. Please check with your own licensing body to determine whether these credits are accepted by them. If you'd like to claim credit for this time, you'll be guided through the appropriate steps once you complete the evaluation. That being said, I'd like to introduce our speakers today. Dr. Scott Hadland is an adolescent medicine specialist at Boston Children's Hospital and Harvard Medical School. Dr. Hadland is a member of the Massachusetts Commission on LGBTQ Youth, an independent state agency aimed at promoting the health and well-being of LGBTQ adolescents and young adults in Massachusetts schools and communities. He is also a member of the Institutional Review Board at the Fenway Institute. Dr. Hadland's clinical and research interests focus on substance use and other risk behaviors among youth. He received his MD from Washington University in St. Louis and his MPH from the Johns Hopkins Bloomberg School of Public Health before completing his pediatrics residency and chief residency for the Boston Combined Residency Program. He is subspecially trained in adolescent medicine and in addiction medicine. Abigail English is the director of the Center for Adolescent Health and the Law, which she co-founded in 1999. She is a lawyer, researcher, and advocate for the rights of vulnerable young people. She has participated in major litigation affecting the legal rights of children and adolescents, lectured widely to youth-serving professionals, and taught courses in public policy, law, and public health. Her research and advocacy have focused on health insurance and public financing of care for adolescents and young adults, consent and confidentiality protections, and sexual and reproductive health care. She received her undergraduate degree from Harvard University and her law degree from UC Berkeley's Bolt Hall School of Law. She was a Gallagher Lecturer for the Society for Adolescent Health and Medicine in 1987 and received the Child Advocacy Award from the American Bar Association Young Lawyers Division in 1997 and the Outstanding Achievement Award in Adolescent Medicine from the Society for Adolescent Health and Medicine in 2000. In 2010-2011, she was the Frida L. Miller Fellow at the Radcliffe Institute for Advanced Study at Harvard, where her work focused on sexual exploitation and sex trafficking of adolescents and young adults. And with that, I'm going to officially turn it over to Dr. Hadland to begin today's presentation.
Well, thank you so much. It's really an honor to be here today, and really a wonderful opportunity for me to have the opportunity to present with Abigail English, who really is a leader in adolescent health and the law, recognized really throughout North America and indeed the world. The focus of my part of the talk, which will be the beginning part here, is really to discuss some of the healthcare disparities that are pertinent to adolescent healthcare, particularly as it pertains to LGBTQ youth. we have no disclosures, either of us. And so my specific learning objectives for this particular presentation will be to, one, understand concepts of sexual and gender identity in a developmental context. Two, to identify the unique challenges and health disparities experienced by LGBTQ children and adolescents. And I'll take a quick note here to highlight that when I use this term throughout the presentation, I'm referring to lesbian, gay, bisexual, transgender, and queer and questioning children and adolescents. Three, to become familiar with strategies to create an affirming and competent clinical space. To do clinical activities such as history taking, the physical exam, screening, and communication with LGBTQ youth and their families in this regard as well. And then four, to access and provide to you additional resources for improving the health and well-being of young LGBTQ patients. So we've already gone through these particulars to Fenway, and so I'll slide through these relatively quickly. But I will say, as somebody who provides healthcare to adolescents and young adults who may identify as LGBTQ, the Fenway website, which Adriana put up earlier on, is actually a very wonderful resource for clinical guidelines and other publications that can help guide all of us as we aim to provide better care to this population. And that website will pop up again later when I list the resources that we've gathered for you. So why is it important to understand how to care for LGBTQ youth in your practice? Well, unfortunately, as I'll cover here, many LGBTQ youth are at higher risk for poor health outcomes. And these health risks are not due to an individual's sexual orientation or gender identity per se, but rather the result of stigma and isolation and discrimination that they face in light of who they are. And so as providers in school health centers and other settings, you can really play a major role in changing this experience for young people who identify as LGBTQ. And in fact, since we know based on surveys that anywhere from 5 to 10% of individuals self-identify as LGBTQ, it means that you're probably already caring for these youth in your practice, whether you realize it or not. And so as somebody who provides care to this population, I think one of the things that I personally find really overwhelming, and that I think a lot of people find overwhelming, is the abundance of terms. I think it can be really difficult to keep on top of all the different terms that people use to describe themselves and how various individuals self-identify. But I really want to take some time right now to flesh these out a little bit, discuss a little bit more, and really kind of try to take some of the mystique off of these terms and show you ways that even if you can't keep on top of them, you can still provide competent care to this population. One model that we often use in our clinical practice when we're trying to explain the different components of an individual sort of identity and expression is this, the genderbread person. This is freely available online, and a lot of people really like this model, as do I. And what this shows is that an individual can really sort of identify along 4 different axes listed here in different colors. The first axis is gender identity, and this is really how somebody in their head sort of defines their gender. And this can be anything from a woman to a man along a spectrum, or perhaps neither. The next item that you'll see listed there in yellow, the second item, is gender expression. And this really represents the ways that you present your gender to the outside world. So whereas gender identity is more of an internal sort of way of thinking about yourself, gender expression is really how you portray yourself to the outside world. And again, this can be any sort of degree of femininity or any degree of masculinity. Sometimes it takes on components of both, and sometimes it takes on components of neither. The third component to an individual's sort of overall identity is their biological sex. And this is probably the most classic way in which people have always thought about gender. This really represents the physical sex characteristics that an individual is born with and develops through puberty. And this includes things like genitalia, body shape, pitch of one's voice, body hair. And again, this largely, as we know, because there are sort of different sexual variants that we see in medicine, really, again, lies on a spectrum from sort of more female to sort of more male. Again, in certain individuals can have components of both, and these can actually be altered through through plastic surgery, as we know, for example. And then the fourth component to an individual's overall identity is really who they're attracted to. And so this is represented in the red boxes here. And there's sort of a 4A and a 4B here. 4A really represents who somebody is sexually attracted to. Are you sexually attracted to women, females, individuals who are more feminine? Are you more attracted to men and males and those that are more masculine? Are you attracted to nobody? Are you attracted to both? And this is really sort of along the spectrum of sexual attraction, because there's actually an additional component to this that often can differ as well, and this is the idea of romantic attraction, whether you're romantically attracted to the same people that you feel sexually attracted to, and those don't always perfectly align. So I just want to take, with regard to those first two that were listed there, gender identity and gender expression, this is an area that's received a lot of discussion in recent years, and so I'd like to spend some time just sort of fleshing this out a little bit more. Gender identity, again, this is sort of a person's internal sense of their gender and whether they consider themselves male, female, both, or neither. And we really do think that all people have a gender identity, and again, that gender identity can be none, but everybody has something, and so it's often clinically relevant for us to understand what that identity is if an individual patient feels comfortable disclosing it. Gender expression, again, is really the idea of how an individual presents him or herself or themselves through their behavior, mannerisms, speech patterns, dress, and hairstyles. And again, this can be on a spectrum, with some individuals having certain components of their gender expression that are more masculine and other components that might be more feminine and others that might just be more neutral. And then the part of this discussion that really just sort of merits a little bit of extra discussion is the T in LGBT, which is transgender. Because this is a component of gender identity that has received a lot of attention recently, particularly in the lay press, in entertainment, and increasingly is something that is important for those that provide care to LGBTQ youth. It's increasingly important for us all to understand. And so transgender is really, at this time, an umbrella term that really just sort of captures all individuals that have a gender identity that's not congruent with the sex that they were assigned at birth. So an individual may have been born in the delivery room with a penis and may have been raised as a male because of that, but then somewhere along the line comes to realize that their gender identity is actually more female. And therefore it doesn't match up with the sex that was assigned to them. And individuals like this may self-identify as transgender females. You'll hear a lot of different terms. Some individuals want to be called transgender women if they are somebody who was formerly assigned a male sex at birth, but then ultimately lives according to their female gender identity. They may just prefer to be called a trans woman. They may prefer to be called just a woman without the word trans in front of it. And often in the medical documentation that we'll do in clinic, we'll refer to these individuals as male to female transgender individuals, just to be very explicit about the medical history. And along those lines, the reverse, if an individual was assigned a female sex at birth but ultimately lives out a male gender identity, that individual may self-describe as a transgender man, a trans man, just a man without the trans in front of it, or a female to male individual. And then increasingly, we're learning that a lot of youth really don't see themselves as having one of these two binary outcomes, and will sometimes describe themselves as genderqueer. And this is really meant to reflect the fact that gender identity is increasingly described as being on a spectrum, despite the sort of very binary presentation that I just gave you above in the same slide. And here's where the terminology I find starts to get a little bit overwhelming for many practitioners. And that is that, as you can see here, there are a lot of other terms that sometimes people will tack on to LGBTQ. And this is very understandable. Although it feels overwhelming, we're really trying to generate inclusivity here, to really allow all people to be at the table and involved in discussions of being part of a sexual minority or gender minority. And so some things that you'll see tacked on to LGBTQ include not just lesbian, gay, bisexual, transgender, queer questioning, but also intersex, two-spirit, which is a term often used by Aboriginal individuals, an ally of people who are LGBTQ, so not necessarily themselves LGBTQ, but supportive and helpful. And increasingly individuals who self-describe as asexual, meaning that they don't have any sexual preference. And these terms are really evolving along with cultural trends. As we know, queer is now widely used by youth and older individuals as a label of sexual orientation or gender identity that's different from pre-existing norms. And you'll sometimes see that queer, or gender expansive are terms that are used that reject these binary categorizations of gender and sexuality and really reflect the fact that these things are on a spectrum and are more fluid. And increasingly, we're hearing more youth who prefer to use non-traditional pronouns. Some people refer to themselves as yo, as ze, as they, as here, as they. These are all sort of terms that really try to take the masculine or female sort of components out of the he and she that we typically use. And although it can sometimes seem confusing for us as healthcare providers, I'll talk shortly about why this is important. And this is why it's important. It's really that terminology really, the language that we use really validates the identity of individuals. And yes, these terms are constantly changing. And yes, it can sometimes be difficult to know what is appropriate or could be offensive. But really dealing with this issue in a caring and thoughtful way is very important because many young people really sort of see the language that they use as validating their identity. And so, probably the most practical, simple piece of advice to take away from this conversation is that you should just ask youth, ask in a very open and respectful way what terms and what pronouns they prefer. So you can say to an individual who's in front of you, how do you identify? What would you like for me to call you? And this is really important because there are a lot of developmental challenges specific to being an LGBTQ youth. So I think that sometimes as practitioners, it can almost feel like the complex terms that are being thrown at us are almost just there to sort of trip us up. But really what we're getting at here is trying to develop a culturally competent, affirming and inclusive space for youth who come to our practices. And so it's really important to establish a comfortable sense of sexual identity and gender identity for youth. And so we need to be cognizant of that in clinic. Youth are constantly deciding when and to whom to come out to. They're constantly, in many cases, coping with external homophobia or transphobia coming from other individuals. In compounding this, many youth are struggling with their own internal homophobia or transphobia. And I know that seems like perhaps a strange idea to some people that you could yourself, for example, be a gay adolescent male and have homophobia. But the truth is that for many youth, especially if they grew up in particularly not accepting environments, it is possible to ultimately have a sexual orientation that runs contrary to your own internal feelings and to have that result in significant stress. And then youth are constantly trying to seek out supportive peers, role models, and family members who they see as allies in this process. And as I mentioned before, LGBTQ youth face significant health disparities. And again, these aren't health disparities that are born immediately out of the fact that a youth self-identifies as lesbian or that a youth has ultimately realized that they're transgender. It's really sort of the context in which this coming out process emerges. And really the mediators or in the middle of this, the sort of intermediates in this pathway are really stigma and discrimination and marginalization, which, as we know in our current society, is very common for youth, and which really sort of helps to explain the increased health risk behaviors and behavioral health issues that youth have. And so some of the things that youth will experience include family rejection, violence in school, social stigma. And all of these things, among others, lead to increased stress. And it's this stress that's really felt to predispose youth to adverse risk behaviors and disparities in health outcomes. Rather than that individual being LGBTQ themselves, it's really these sort of adverse consequences and adverse environments that result in stress and result in these disparities. And then further complicating all of this, many youth who are LGBTQ have barriers to accessing healthcare, so they may not even get into our doors. Some youth have difficulty finding LGBTQ welcoming healthcare organizations. And some youth will actually delay seeking care for a particular issue because they believe that the providers will not understand their particular needs as an LGBTQ individual. And then complicating this even more, LGBTQ youth are actually more likely to be homeless and can also sometimes be rejected by family, ultimately resulting in them being estranged from family, perhaps run away from home, which, as you can imagine, leads to other barriers to care, such as lack of transportation, because often youth need parents to drive them to health appointments. And families that reject youth may actually not be able to, may not willingly provide them with insurance coverage if the family is not supportive of their orientation or identity. And so how do we combat this as healthcare providers? Was our role really to create a welcoming space right from the front door? And this starts before youth even enter your exam room. Some things that many clinics will do is they'll have small little LGBTQ positive or inclusive messages in windows or on posters. And it may not seem like much, but even just a small rainbow sticker in the corner of the window that youth check in at when they come to the front desk really goes a long way. I think that for most youth who don't self-identify as LGBTQ, they probably just look past these small stickers and displays and don't even perhaps notice them. But even just a tiny sort of like 2-inch by 1-inch rainbow flag, I think, can very easily be sort of detected by LGBTQ youth who are constantly sort of seeking out these affirmative messages. Other things that clinics can consider doing, many clinics will have forms and material that are available in the wait room that are forms that youth have to fill out about themselves and their medical histories. They may have brochures about safe sex behaviors and other items that are pertinent to adolescent health care. And it's really important that these forms and these materials really reflect the diversity of LGBTQ people and their relationships. And so maybe your forms don't just say male or female, but actually allow for other more inclusive answers for youth who may not identify as others. And then it's important to train registration staff right at the front door to provide respectful, non-judgmental service regardless of identity. And creating a welcoming space from the front door really, again, it can actually be facilitated by a number of trainings that are available. So, for example, we recommend here at Boston Children's Hospital that all staff be trained on LGBTQ health and competencies. In our adolescent clinic, we offer single-stall, gender-neutral bathrooms to make sure that youth can use the bathroom with which they identify. And a lot of hospitals and clinics will specifically include gender identity and sexual orientation in their non-discrimination policies there at the clinic, and may even go so far as to incorporate it into their clinic's mission statement. As Abigail will discuss, it's really important to have office policies that respect adolescents' legal right to confidential care. And one thing that I've put here is that clinics can consider safe space or safe zone training. These are specific trainings that are available, in some cases free of charge or at a very low charge, where external trainers will come in and actually do a training with all front desk staff and clinical providers to make sure that everybody is creating a welcoming space right from the front door. And so a few specifics on the clinical visit, just to make this really sort of offer you some practical advice. The goals of LGBTQ adolescent healthcare are really the same as that for providing healthcare to all adolescents. We really want to promote healthy development, to promote social and emotional well-being, and to promote and ensure physical health. And I think the one sort of thing that looms over many people's heads is how to talk to youth about their sexual orientation and gender identity and how to do it on their terms. And I think the first thing that's most important for people to know is that it's not your job as a clinician to get youth to come out to you. What your job is as a clinician is to create an affirming and inclusive environment in which youth feel comfortable disclosing themselves to you when they're ready on their terms, and that you're available to provide support and resources. That's really much your role than getting somebody to disclose who they are. And so some youth may not disclose their sexual orientation or gender identity to their clinician, and that's okay. Some youth will reject labels and may see their sexual or gender identity as fluid, and we should be accepting of that. And so we should really let patients use their own terminology for their identity, even if it doesn't match their sexual behaviors. And so one thing that many clinicians in our practice will do is really take a psychosocial history that has a strength-based approach. And many will use this SHADES acronym. Again, these slides will be available to you afterwards. If you like this, you can give it a try in your own clinical practice. So in many adolescent practices, people will use the HEADS mnemonic. Sometimes it's got 2 S's at the end, sometimes it's got 2 D's in there. But the bottom line is that it's a mnemonic that many practitioners will use to get at the adolescent's home life, education, activities, drugs, depression, sexuality, and safety, really to sort of screen for major causes of morbidity and mortality in teenagers. What many practitioners will do in our clinic is actually reorder these components and actually do what we call a SHADES psychosocial history, which really puts up front an adolescent's strengths and sort of puts up front things that are easier for youth to talk about with their provider. And so under this SHADES mnemonic, the order becomes strengths, school, home, activities, drugs, emotions and depression, sexuality, and safety. And so you can see here that really things that youth might feel more comfortable talking about are really up front, and then you get into the heavier stuff, and is really taking a strengths-based approach, which is empowering for youth. And then, of course, throughout all of this, it's important to discuss confidentiality, which is really going to be the focus of the second part of this discussion. How to discuss sexual health and sexual identity? Well, really, it's a matter of practice. If you look or feel uncomfortable asking, youth may not feel comfortable giving honest answers to you. And so that's why just practicing it and just becoming facile with it is the most important thing that you can do. And I promise you that if you create an open and affirming and inclusive dialogue with youth, even if you don't feel comfortable with the terms, even if you struggle through them, youth will read through the lines and understand that you're an open provider who is willing to talk about these things and provide support. It's important to avoid assumptions as well. As I'll discuss in a second, it's really important to address pregnancy prevention with women based on their sexual history rather than their stated sexual orientation and gender identity. And so it's important to be specific and to be complete. What some people will do to be both of these things is to use a framework that asks youth specifically about their attraction, who are you attracted to, about their behavior, who do you engage in sexual activity with, and about their orientation, how do you self-identify? And that really gets at sort of multiple of those components that we've discussed in this conversation. And as far as sexual risk counseling is concerned, it's really important to address sexually transmitted infection and HIV and pregnancy risks based on sexual activity rather than an individual's stated identity, because these two things don't always align. So a really critical example of this is that teen pregnancy can and does often occur in lesbian and bisexual girls, and also is something that gay and bisexual boys can be involved in as well when they have sex with a female partner. And in fact, there was a recent study that showed that risk of pregnancy was actually higher under females who self-identified as LGBTQ compared to those who self-identified as exclusively heterosexual. And in fact, lesbians and bisexual girls may be less likely to use contraceptives according to some recent data. With regard to safety, violence, and victimization, it's important to screen for these things. There's some data to suggest that some youth who are LGBTQ may be at elevated risk for victimization. And so it's very important as you ask about home, school, and friendships to ask how things are going in these settings and whether youth feel safe in these settings. And be prepared in your clinic with resources and referrals on hand. And again, we have some of these available in this talk. Some questions you might consider asking are the following. How are things going at home or at school? Do you feel safe when you're at home? Do you feel safe in your neighborhood and at school? Has anybody ever picked on you? Can you tell me about it? Was this because you were LGBTQ specifically? And then a common screening question that's on many questionnaires that's felt to be a very broad, sort of open-ended one that may get at all forms of victimization is this one. At any time, has anyone hit, kicked, choked, threatened, forced himself or herself on you sexually, touched you in a sexual way that was unwanted or otherwise hurt or frightened you? And I know this sounds like a very overwhelming question. This is not one I would ask my patients in exactly this wording, but it gives you an idea of all the different ways that youth can be victimized. And some people will use this exact wording in questionnaires that youth answer on some of the sort of standardized forms to make sure that all forms of victimization are being adequately captured. And for youth who may have been abused or victimized in some way, or who are survivors of sexual victimization, physical exam can be particularly invasive. And so it's always important to tread a little bit lightly here and make sure that the youth we work with feel comfortable. So as part of your SHADES examination, many people make sure that they assess for abuse or forced sex so that can help guide the level of comfort a youth might have with a physical exam. The exam can be very traumatic for trans youth who may not identify with their anatomy. So an individual who is born a biological male but now self-identifies as female may have an outward gender expression that's female, but actually may still have a penis. And it's important for providers to, at times, examine that penis if there's concern for a sexually transmitted infection. And that can be very traumatic for individuals who are transgender. And so it's very important to explain why and how you'll examine these sensitive areas before you do it, and give adolescents, really empower them, give them the opportunity to say yes or no to that exam. And what many practitioners will do is that, we don't always have to do an exam of the genitals if we're still building trust with a youth, if there's no particular concern in that area at that particular visit. And so it's okay to defer, even though we're taught to always do a complete physical exam. If that's going to disrupt the trust you're trying to build with youth, then perhaps it's not the time to do it. And then there are certain strategies that some practitioners will use to increase comfort. If you're doing a pelvic exam, sometimes it's helpful to have an additional person in the room who's available to sort of help hold somebody's hand or provide music or help with relaxation for an individual undergoing that exam. And then it's important for practitioners to support youth who are coming out. As youth who are thinking about coming out, they may actually approach their provider and ask for tips. We always say that safety is first. It's important to assess whether that youth coming out will be at increased risk of losing housing or financial support from family, or be at risk of violence from parents or peers. And then it's important to strategize around who to tell first. I think it's always helpful to help youth brainstorm if you're so fortunate as to be in the position of being able to counsel youth through this really important process in their life, to help youth figure out who they can trust and who will be supportive of coming out. And it's also helpful to really help youth have the long view. They should understand that individuals' feelings really change over time. And so bad reactions from parents, from siblings, from peers, from other members of the community might be initially bad, but they may not stay that way forever. And in fact, I think we often do people a disservice when we think that people can't handle knowing about LGBTQ status of individuals, that many people can and frequently do change. Some practitioners will even role play to practice and sort of help come up with contingency plans if things don't go as planned. And then my last slide that I want to cover here is really addressing the concerns of parents of LGBTQ youth, because this certainly comes up a lot. A lot of parents will have questions such as, did I do something to cause this? Can my child who's LGBTQ still have children? They may make statements like it's going to be hard for him or her. And it's really important with parents to focus on the positive and provide resources and support. Again, we'll offer you some of those in this presentation. And really be clear, the evidence really does show that parental love and support lead to better physical and mental health outcomes for LGBTQ youth. And so it's really important to highlight to parents that if they're worried about things being hard for their child, the truth is that they're probably the single most important buffer to making that not the case. So I've listed here some really critical resources that can be available. We'll make these slides available to you after the presentation, and so I really welcome you to click on these and check out what they have to offer. I'll note as well that specifically with regard to managing transgender health, there actually are Endocrine Society guidelines created in 2009 that can really sort of help practitioners work through the sort of medical side of transgender management. And so I recommend, if that's important for you to read, that you check out this report. And then there are resources specifically for LGBTQ youth and their families, which are listed here. And again, this is really helpful to have on brochures and other reading material at your clinic. And there are hotlines for support and for referrals for sort of more urgent needs for youth who just really need someone to talk to in the moment. And so these are really important numbers to consider providing to your patients as well. So I'd like to thank Nadia Daushin and Rob Garofalo, who helped with the development of this presentation. And with that, I'd like to turn over to Abigail English, and we're so fortunate to have her speaking today. Thank you.
Thank you so much, Scott, and thanks to the National LGBT Health Education Center and the School-Based Health Alliance for organizing and sponsoring this webinar. I would just like to say I learned so much from Scott's presentation. I'm really feel privileged to have been part of this event because it has increased my awareness of a lot of aspects of this set of issues. So thank you very much, Scott, for a great presentation. And thank you all for participating in the webinar today. And we're looking forward to your questions for both of us at the end of my part of the presentation. So I will just move right into it and say that what I'm hoping to do today is to explain that in very basic ways the consent and confidentiality laws that are related to sexual and reproductive health care and other health services for minors and young adults, and then explore a little bit how those laws, particularly the minor consent laws, apply to LGBTQ youth, and then explore some of the confidentiality issues related to sexual orientation and gender identity for LGBTQ minors and young adults. And I've used the phrase minors and young adults or adolescents and young adults a number of times in this presentation because even though I think we're mostly targeting the presentation at adolescents, and particularly because it's co-sponsored by the School-Based Health Alliance, to school-age young people. There are a number of young people who are 18 and 19 years old who are still in high school, and they are technically legally young adults, and so it's important to keep that distinction in mind. I won't dwell on it, but I did want to mention it. Just by way of introduction, the School-Based Health Alliance has is sponsoring a series of confidentiality webinars that began in late 2014, and the first two focused in quite a bit of depth on the laws and the clinical application of the laws in the school-based health setting of around consent and confidentiality. And then there was another one at the end of 2015 that focused on communications in the health insurance and billing arena and explanations of benefits. And those webinars are archived on the School-Based Health Alliance website and available to you. So what I'm going to do today in the time available is talk a little bit very briefly about the rationale and the research support for confidentiality, the legal requirements for consent in state law and for confidentiality in state and federal laws, and then the relationship between consent and confidentiality, which is always important to revisit, some of the special disclosure issues that are of particular noteworthiness, and then closing with some particular considerations for LGBTQ youth. So moving right into it, I like to begin presentations about these issues with some revisiting of topics related to both parents and adolescents, and to remind all of us that there's a lot of communication that does go on between parents and adolescents, and much of that is voluntary communication. And when parents are supportive, that communication can be very helpful and very positive, and often is facilitates a lot of disclosure by adolescents to their parents about issues that are of great importance in their lives. That when we move into an arena of mandated communication, and when families are dysfunctional, that can be actually harmful or certainly not supportive and helpful. But in addition, mandated communication is not particularly helpful when adolescents are going through a normal evolution of developing their autonomy and their ability to act independently as they mature. But throughout all of this, ultimately, the interests of adolescents and their parents are or should be in concert, that what we all want as healthcare providers and advocates, as well as adolescents and parents, is for young people to be healthy. Unfortunately, as Scott mentioned in his presentation, sometimes families have a hard time being as supportive as they might be, at least initially, for LGBTQ youth. And so there may be some heightened risks and challenges around communications and disclosure for this population. And healthcare providers need to be sensitive to that and help young people navigate that territory. So the underlying rationale for confidentiality protection in the law is to avoid negative health outcomes and to protect the health of adolescents, and also to protect the public health, and to do so by encouraging adolescents to seek the care that they need. The confidentiality protections that currently exist have been supported by decades of research findings, and those findings have documented repeatedly that many, indeed most adolescents have privacy concerns, that both adolescents who are minors and young adults are often concerned about disclosure of information that relates to sexual behaviors, substance use, and mental health, and they're usually most concerned about the disclosure of that information to their parents. LGBTQ youth have additional concerns about disclosure. They may be concerned about disclosing sexual behavior, substance use, mental health concerns, but they also often have extra concern about disclosing their sexual orientation or their gender identity. And I love the slide that Scott used to sort of display the multiplicity of terms, and I'm obviously short-circuiting that by using just these two. But they may be concerned not only about disclosing these things to their parents, but also, as Scott mentioned, to their peers, to their community, to their teachers, their schools, their other contacts out in the world. So that is also an important aspect of confidentiality that hasn't really been addressed very well yet in the law, as we'll see as we go on. So the effect of these privacy concerns on the part of young people can influence whether they seek care, when they seek care, where they seek care, and if they do seek care, how openly they talk with their health care provider. So that is, again, a set of really important reasons why we need to protect confidentiality. So I've discovered over many years of talking with people, both in formal presentations like this and just informally, that consent and confidentiality are two terms that tend to be so linked that they almost become a single word, consent and confidentiality. And they are linked in many ways in clinical practice, in ethical guidelines, in professional policies, and in state and federal laws. But it is very important to keep in mind that legally they are distinct concepts. They are not the same, and that confidentiality does not always accompany the right to consent. So we'll explore a little bit what the limits of that are. But it is also important to keep in mind that issues of confidentiality and disclosure are often addressed in the consent laws. So I want to talk a little bit about the consent laws. These laws, in terms of minor consent, began to be enacted in the 1950s, which is now quite a long time ago, more than half a century. There were very few such laws that long ago, but in the 1960s and the 1970s, the laws really began to proliferate around the country. And so many of the laws that are currently on the books have been enshrined in state statutes and regulations for decades at this point. And there was a period of relative stability without too many new laws being enacted and without any laws being repealed. And then in the 1990s and the 2000s, we began to see periodic efforts in a variety of states to limit the scope of these laws or even to repeal them. I'm happy to be able to say that at this point, the laws, despite repeated efforts in some places, have not been repealed, but the efforts to do so do continue. So every state and the District of Columbia do have minor consent laws. In addition, and that's what I'm going to focus on primarily, but in addition, there are some situations where not only the minor consent laws specifically, but other legal provisions form an exception to parental consent, such as the ability to provide care in emergencies without prior consent, and the ability for judges or foster parents or child welfare agencies to give consent. But primarily, the major exceptions to the parental consent requirement are in the form of minor consent laws that exist in every state related to the status of the minor or the services the minor is seeking. And I'm not going to read the entire list, but there is a wide array of different situations in which a young person may be able to consent to their own care because they have a particular status, such as having attained a certain age. In Oregon, it's 15, or having graduated from high school in a few states, or living apart from their parents and being homeless, which, as Scott mentioned, may be a particularly important status for young LGBTQ youth. So not every state has recognized every status on this list. Only a few states have either all or most of them, but all states have at least a few of them. So it's important to know which ones are applicable in your state. Then there are the laws that allow minors to consent to their own care based on the services they're seeking. And a big umbrella term that's used or that conceptually is applicable is pregnancy-related care. And under pregnancy-related care, minors usually may consent to contraceptive services or family planning and to prenatal and maternity care. However, minors often may not consent to sterilization or to abortion, at least not without parental notification, parental consent, or a court order related to their maturity, their being mature, or it being in their best interest to do so. So I think at this point, I think it's about 40 states that have parental involvement laws for abortion, but all of those states do also have some kind of a bypass, a judicial bypass, or some other kind of mechanism where a young person can avoid the necessity for parental involvement if there's a compelling or health reason for them to do so. So other consent laws that are based on the services that a young person may be seeking, a minor may be seeking, relate to the diagnosis and treatment of STDs, reportable disease, and HIV testing and treatment. And I've put the words prevention in color and in parentheses there because there are a few states now that do allow minors to consent to care related to prevention of STDs or reportable disease. And this can be very helpful in relation to immunizations, for example, the HPV vaccine. In addition, the vast majority of states allow young people to consent to drug or alcohol counseling and treatment, and to patient mental health services, and then a smaller number of states to diagnosis and treatment for sexual assault. So the question now is, how do these consent issues work or play out for LGBTQ youth? And the answer to that is that there is not a simple answer. There is no status LGBTQ in the minor consent laws of any state that I'm aware of. And there is no minor consent law that says that young people or minors can consent to services that are particularly related, for example, to being transgender, to some of those services. And one might think, well, let's get them enacted. Let's put them on the books. And I would say that that's certainly a very understandable thought, but that could be challenging and could be politically extremely difficult to achieve in this current environment. So short of that, and not wanting to sort of rock a boat that's sailing along in fairly calm waters at the moment, it's important to realize that LGBTQ youth may be able to give their own consent for a fair amount of care that they need, either because they also occupy a status like being homeless, or living apart from their parents, or having graduated from high school, or being of the age in their state that allows them to consent to care, and so on. So that is one option that needs to be considered. Is there a status-based reason why an LGBTQ young person who can't or doesn't want to involve their parents should be able to consent for their own care? And the other is that, as Scott mentioned, they may be at heightened risk for a number of the health conditions and concerns that allow them to consent to specific services like mental health services, sexual services, and so on. So there may be a number of options for LGBTQ youth to consent for their own care. And the next question is, if they can consent, can the care be confidential? Or even if they don't consent, even if they can't consent independently, is there any way in which their care can be confidential? And that really depends upon the sort of interrelationship of a large number of state laws and federal laws. And again, I'm not going to read the list, but the state confidentiality laws, as you can see, fall into a wide array of different categories, including notably the minor consent laws. and some other laws related to medical confidentiality and medical records, some of which specifically reference the minor consent laws. In addition, there is a wide array of federal confidentiality laws, and I would say most notable among those and relevant for today's discussion are the HIPAA privacy rule, Medicaid, and the Title X family planning confidentiality regulations. But it's important to note that some state laws, particularly the minor consent laws, may have considerable significance in the application of federal laws, and I'll explain in a moment what I mean by that. So the HIPAA privacy rule, which is the monster in the room always, treats minors as individuals in three situations. If they have the right to consent to their own care and they have consented, if they can get care without parental consent and somebody other than a parent has consented, or, and this is very important, if parents accede to a confidentiality agreement between the minor and the healthcare provider. So there may be situations in which an LGBTQ youth comes into a clinic with a parent, but it's important that they have a private conversation with the healthcare provider. And if the healthcare provider explains that and the parent says, yes, it's okay for you to talk to Johnny or Susie confidentially, that has legal significance under the HIPAA privacy rule. So if minors are treated as individuals, it allows them to exercise some rights over their own protected health information, accessing it, sometimes controlling its disclosure, and requesting special privacy protections that are available under the HIPAA privacy rule. And those special privacy protections fall into two groups. The first is that individuals may request restrictions on disclosure of their private health, personal health information. And healthcare providers and health plans are not required to agree to those restrictions on disclosure. But if they say they will, if they say they agree, then they do have to comply. In other words, they have to stick to what they've agreed to. They also have to agree if the care is paid for in full somehow other than by a health plan. So if a young person is not using their insurance and there's no health plan payment involved, and there is no sort of residual financial cost, the care has been either fully paid for or it's free care, then the individual may request restrictions, and those have to be honored. And so the second category is that individuals may request confidential communications by alternate means or at alternate locations. In other words, communicate with me by email or don't send it to my home address. And providers have to grant reasonable requests, and they may not require an individual to claim that they're endangered if their communications go somewhere else. Health plans have to accommodate reasonable requests, but they can do so conditioned on the individual saying that they would be endangered if the information goes somewhere else. This is important because even though not all LGBTQ youth have insurance and not all can use their insurance, some can and some do. And so it's important to know about these options under the HIPAA privacy rule. Also, under the HIPAA privacy rule, there are some specific standards about disclosing information to parents. And if state or other law requires disclosure to parents, which mostly occurs with respect to abortion and then a few other categories we'll talk about in a minute, then the provider has to disclose. If the state or other law other law prohibits it, the provider may not disclose, or if it prohibits it without the permission of the patient, as in Title 10, that's applicable. If state or other law permits it, that gives the provider discretion to disclose. And similarly, if the state or other law is silent or unclear, the provider has discretion to disclose or to withhold access to the information. So again, this is the way that these state and federal laws are intertwined with one another. The HIPAA privacy rule also allows disclosure without authorization for certain purposes like treatment, payment, healthcare operations, and some other exceptions, which we'll get to momentarily. But it also allows for disclosures with authorization, even apart from those purposes that I've listed above. And so if a young person is an adult, 18 or older, it would be their authorization that would be required. And if the young person is under the age of 18, whether the authorization would have to be by a parent or by the minor would depend on whether the minor was treated as the individual and these other issues that I've previously described. So, as I mentioned, there are explicit protections of confidentiality in some of the minor consent laws, and there are references to the minor consent laws in some other statutes that protect confidentiality. But importantly, in a number of laws, there is a grant of discretion to the physician or the healthcare professional to disclose information, either if it's necessary to protect the health of the minor, or that it should not be disclosed if the minor's health would be harmed by the disclosure. And so I think this is of particular significance in the LGBTQ context because, as Scott mentioned, there may be some young people who are LGBTQ and who are at enhanced risk in their homes or in their communities, and for whom disclosure of the kind of information that may be not so significant for other young people, for them might place them at increased risk of some sort. So this discretion, exercise of discretion by physicians and other healthcare professionals is of particular importance and has to be exercised very carefully. So in the few more minutes that I have, I'm going to talk about a few special disclosure issues. I've already mentioned parental notification and consent requirements, but we need to address child abuse reporting and disclosure requirements when a minor is dangerous to himself or herself, and I can't use all those wonderful pronouns that Scott mentioned, or to others, and some issues related to billing and health insurance claims. That last one, billing and health insurance claims, was the subject of an entire webinar that's archived on the School-Based Health Alliance website, so we're not going to delve into that much today. But it is important to note that services that do fall outside the minor consent laws ordinarily would require parental consent, and that limits confidentiality because the parent knows about the service. That's an obvious statement, but I think one worth repeating. We've already mentioned that most states do require parental involvement for abortion, but have exceptions and bypasses. And some of the minor consent laws require parental notification, but do contain exceptions if the health of the minor would be harmed. Child abuse reporting laws are really very significant in this context. Every state has them. They require reporting of physical abuse, emotional abuse, sexual exploitation, and or sexual assault. Some of the laws, I think it's about a third of states, only apply if the perpetrator is a parent or a caretaker. But some LGBTQ youth may be subject to abuse by a parent, in part because of their parent learning about their LGBTQ status. So it's possible that a situation could arise where a child abuse reporting law might be applicable, and that could lead to some uncomfortable situations that would have to be addressed very sensitively with the young person and ultimately perhaps with the parent as well. In addition, some laws have been interpreted or explicitly do require the reporting of voluntary sexual activity of minors, and this would depend on how sexual abuse, sexual exploitation, and sexual assault are defined in the child abuse reporting law. It would depend on the age of the partners or partner of the young person, as well as on other factors, such as how local prosecutors and law enforcement and child welfare agencies are interpreting state laws. So this, again, might be of significance for a young person who is perhaps lesbian or gay and may have an older partner, even if the age difference is not enormous. If there's one partner that's an adult and the state child abuse reporting law is written in a particular way, that could trigger the need to make a report. Always an exception to confidentiality is that healthcare providers have legal and ethical obligations to disclose when a young person is dangerous to self or to others. And that obligation may vary depending specifically on some state legal standards and case law, but certainly if there's an articulated threat to an identified other person, that would trigger a need for disclosure either to law, perhaps to law enforcement. And if the young person is dangerous to self, that could trigger an obligation to disclose to parents or to take some other protective actions. And again, I'll just mention with regard to the billing and health insurance claims that there are a multiplicity of laws that require certain kinds of disclosures, such as for explanations of benefits or denials of claims, but that there are a growing number of states that are developing specific protections to try to address this issue of insurance leading to confidentiality breaches. And these protections build on the HIPAA privacy rule. They may provide for redirection of explanations of benefits, for controlling the content of communications, for providing certain explicit protections for adult dependents, and by defining endangerment in ways that go beyond physical danger and may include harassment or even limitations on access to health care. So I'll just conclude by saying that I think it's important that we remember that LGBTQ youth share a lot of the same concerns about consent and confidentiality that other adolescents and young adults have. In other words, they're not in an arena all by themselves with regard to these issues. And so to the same extent that healthcare providers and professionals who take care of adolescents and young adults generally have to be mindful of the consent and confidentiality laws and the importance of confidentiality protections, so too do they have to be mindful of these things when they're taking care of LGBTQ youth. But it's also important to remember that there are some special considerations that apply for LGBTQ youth. And of course, one of the primary ones has to do with the disclosure of their sexual orientation and or their gender identity. And this is an area in which the law is not very clear at this point, and not very explicit. But as I mentioned, there are a number of provisions in existing laws that are nonetheless relevant. In addition, because as Scott mentioned, LGBTQ youth may be at increased risk for specific health concerns, including suicide or suicidal thoughts. And because they may be at heightened risk for harm at home and in other settings, it may require sort of putting on a different set of glasses and thinking about when the confidentiality concerns are particularly intense for these young people and how the existing laws can be applied in creative ways to protect their interests. So with that, I'll stop and I'll mention that, as Scott said, there are several resources that are listed here that will be available to you to download and to access after the presentation.
Great. Thanks so much to both Abigail and Scott for your presentations. And this is Adriana. I wanted to jump on and just let folks know that we have plenty of time for Q&A. Thanks so much again to Abigail and Scott. I'm going to unmute everybody, and I have a few questions that have been asked throughout the presentation, so we'll start with those, and then we'll move along to the ones that are being asked now. So the first few are for Scott, as they came in when he was presenting. So Scott, are you ready for the first question?
I am, yep.
Great. So the first two are kind of questions and comments, so I'll read them both together. The first is, you may have already mentioned this, but it is also important to point out that some folks whose gender identity is not congruent with their assigned sex at birth may still not identify as trans or transgender. And the second comment / question is, I've read some commentary regarding the term two-spirit, basically saying the term is specific to indigenous cultures, as you mentioned, and that it's used by non-indigenous folks is culturally appropriative. Excuse me. Do you have any thoughts on that?
Yeah, I agree wholeheartely with both of those points. I think they're really astute comments. With regard to the first one, absolutely. So some individuals who we as medical professionals might label as transgender and might say, this is a transgender female. That individual might just identify as female without the transgender in front of it. And so I think that's really important to acknowledge and recognize that sometimes our language we use as medical professionals doesn't align with what youth want to be called. And then with regard to the comment on individuals who self-describe as two-spirited, absolutely. I think that that is a term that's used almost exclusively among Aboriginal populations and is probably most appropriately only applied by those individuals themselves. I agree.
Great. So now this is another question which is a little bit more technical. I'm on board with the folks identifying themselves on or with their own terms, but that complicates collecting data in a healthcare setting since the fields available in an EHR are often at this point very limited or limiting. What are your thoughts on that?
Yes, this is really tricky. I'm sure lots of folks on this webinar work with EHR systems that are extremely limiting, that really just give you an option of identifying a patient as male or female. I think what we need to do as practitioners is figure out small little workarounds to get around that. And what many people will do in our clinic, for example, is if a particular patient might be listed in the electronic health record as male, but that individual is actually somebody who is a transgender female, we'll actually at the top of our sort of routine healthcare notes just make a special note that says that this individual identifies this way. It's certainly something that you want to be careful about putting in the medical record if you're worried about parents accessing records in line with what some of Abigail was discussing. So you want to do it carefully, but there are ways to sort of prompt yourself to make sure that you're reminded to provide affirmative and inclusive care to all of your patients by documenting appropriately. But yes, sadly, electronic health records have really lagged behind in this area.
Yeah, and Abigail, did you want to talk about that at all? I don't know if you have any comments.
Let me just add on to Scott's last comment there that he's identified something that really could be significant, and that is that there's a lot that's in flux right now about who has access when to which portions of the medical record for adolescents and to information through web portals for providers. And so information that goes into different parts of the medical record may or may not be accessible to an individual's parent, may or may not be accessible to other providers in the system or to providers outside the system when records are released. So it is very important to be aware and maybe even to discuss with the young person, if I put this information in your medical record, are you okay if your parents have access to this through the web portal, so that somebody isn't inadvertently kind of outed by this other mechanism.
Yeah, thank you so much. That's great. So this next one is for Dr. Hadlin again. So my clinic currently does routine substance abuse and depression anxiety screening on all youth starting at age 12. Do you have examples of these that include sexual or gender histories on paper? Workflow and confidentiality is always a challenge.
Absolutely. So, I think there's a bit of a divide here among practitioners. I think everybody has the sense that we should be asking these questions of the youth for whom we care so that we know how youth self-identify. There's a bit of a difference of opinion among practitioners right now and no right answer as to whether we should be asking this in the same way that we do about substance use in a screener that is in the waiting room versus having a clinician present it in a really sort of affirming and inclusive way with a patient in front of them, giving them the opportunity to disclose right there in a safe environment. So there's not a right answer as to whether it should be done in the waiting room on paper or in person with the practitioner, or perhaps both is the right answer. And at the end of the day, it may come down to provider preference and just sort of understanding what works best for your patient population. With regard to questions that can be used, there aren't standardized questions, but actually, interestingly, on the Fenway website, and I can work with Adriana to figure out a good way to make this available to everybody. We have examples of the questions that are asked at Fenway Health of patients, and so I can tell you, for example, Fenway routinely asks of all of its patients the following questions, and this is reflected, by the way, in their electronic health record system. So the first question is, do you think of yourself as, and then multiple options are given, lesbian, gay, or homosexual, straight or heterosexual, bisexual, something else, or don't know, followed by another question that asks, what is your gender, with the options male, female, gender queer or not exclusively male or female. Another question asks, what was your sex at birth, female or male? And then a final question that asks, do you identify as transgender or transsexual? Yes, no, or don't know. And so, again, we can make these questions available. They're not validated or standardized across multiple settings, but they may work well for your individual practice and really are meant to get at all of those different components that I presented in the Gender-Bred Person.
Yeah, thank you so much, Scott. That's really great. It looks like the next question is actually for Abigail, so I'm going to try to do my best, but if you need me to reread this, I will. So the question is about, I believe, state laws. So if a state law doesn't specify prevention, does that mean minors cannot consent to HPV vaccines, et cetera?
That's a very good question to which there is not an absolute answer. And the reason is that in some states or in some even local jurisdictions, the health departments have interpreted their state laws related to diagnosis or treatment of sexually transmitted disease to enable young people to consent for HPV vaccine. But it wouldn't be immediately apparent from the face of the state statute. So you really have to explore that in your state as to whether there has been, like a policy letter from the state health department or the local health department addressing this question that would make it clearer that you could provide HPV vaccine, even if the word prevention were not in the state statute. In addition, if a young person occupies one of the status categories that allows them to consent to all care, then they could consent to HPV vaccine. So if they're in a state where homeless youth can consent to all care, they could consent to HPV vaccine. So again, it depends sort of the intersection of several different laws.
That's actually a good lead-in. We had another participant just ask for some clarification around the consent laws for minors around HIV status and treatment.
Okay. I think that what's safe to say is that in virtually all states, at least the vast majority of states, minors can consent to HIV testing. And in a smaller subset of those states, they can also consent to HIV treatment. And there are a handful of states that have some kind of nuances about whether parents have to be informed at any stage along the way, but that's a very small handful. And so in a state where HIV was classified as a sexually transmissible or reportable disease, they would be able to consent to diagnosis and treatment. And then in some states, there's an additional provision that says you can consent to HIV treatment. So again, it's just a question of checking out how your own state's law addresses these issues.
Great. So I have a comment, which I'll welcome either Scott or Abigail or both of you to touch upon. So the comment is, I worry about not getting the identifiers into the electronic medical record because it could shift the standard of care. So if we were to just place a note on a piece of paper or to note somebody how they identify, how does this translate over time on visits? And one thing I'll note before I open it up to Scott and Abigail is that the universal data set for health centers is now there's a requirement coming down the line to collect sexual orientation and gender identity data. So it's not, there are no instruction on how to collect that information from HHS just yet, but there will be. And so this kind of is to say that I think that healthcare providers are aware of this issue of getting the information into the electronic medical record, and it is kind of being addressed. But I wondered if Scott or Abigail had comment on that.
Yeah, I mean, I think that it's really critical to do what we can to capture that information as much as possible. I think we do owe it to our organizations to try to push the envelope forward. Increasingly, different vendors are offering these options, and federal guidelines are changing such that we should be asking these questions. And in fact, our own clinical practice guidelines say we should be asking these questions. So I think that everything is moving in the direction of this being done. And so I would suggest that people really try to be advocates within their own organizations to make sure that these data are being captured through appropriate means to help us to really understand the populations that we serve. Because remember, too, that, amidst all of this, we need to be practitioners who don't just ask these questions, but also use these questions to understand the care that we provide to youth. And so if we want to be measuring outcomes and improving quality for the populations that we seek to serve, we really need to know this information, have it in the electronic medical record, and have it in the record in a way that makes it easier for us to study our own practices and our own outcomes.
Great.
And this is Abigail. I'll just say that that all makes a lot of sense, what Scott just said, and I would be supportive of that. And I think it's important to just think about the implications of how the information is in the medical record and what that means in terms of who has access to it, so that everybody understands kind of what the rules are.
Sure. Great. I have another question for you, Abigail. It says that, can I assume that all of what you said related to consent and confidentiality applies to mental health workers as well as to physical health workers? Oh. Abigail, did we lose you there?
No, I finished. It was a quick comment. Sorry.
Oh, no. Okay, great. Did you hear the second question about mental health workers? I can read it again if you'd like.
No, I did not.
Oh, okay. Sorry about that. So
yeah,
the question is...
I think I lost you, or whichever okay. way. I didn't hear that. Sorry.
So the question is, no problem. Can I assume that all of what you said related to consent and confidentiality applies to mental health workers as well as to physical health workers?
I think that that's a tough question to ask of a lawyer, because technically, to know whether it applies, you have to read the statute and see what the terminology in it is. If it says physician, then technically it means physician. If it says something else, healthcare professional or psychiatrist or social worker or whatever, then it means that. These laws are generally looked to as establishing sort of standards of care, and I use that term very loosely, not in any technical sense at all, so that it really depends on whether you're looking to sort of answer a technical legal question in a particular case where there's a controversy, in which case, the lawyers and the other people involved are going to look to the specific wording of the statutes, or whether you're looking to kind of understand the sort of standard of care. So I can't say, yes, everything I said about consent and confidentiality applies to all mental health as well as physical health professionals, but a lot of it does.
Great. And I think this will be the last question we have time for today. It's for Dr. Hadlin, but if any folks have any lingering questions, you can feel free to email us at lgbthealtheducation@fenwayhealth.org, and we'll try to either get them answered or directed to the right person. So the last question for Dr. Hadlin is, this person says that they are fully transitioned transgender male working with children and young adults. His question is, do you find that children and young adults tend to like to label themselves with different terms in order to understand the fluidity themselves?
That's a really good question, and first of all, I have to say we're really lucky and fortunate when individuals who are themselves LGBTQ are providing health care in settings, because I really think it does help lend an individual sort of personal experience perspective to the care that we provide, and I think that it can be really instructive for all of us, and so I think it's wonderful. That you're thinking about your own practices and how your own personal experiences impact your care. So yes, I think I put up the genderbread person and really highlighted that all of those different dimensions are really kind of on a spectrum. And I guess the one thing I didn't mention is that not only is there sort of a spectrum, from masculine to feminine, and for all those different dimensions, but there's really also an additional dimension of time that these things aren't static; they're very much dynamic, and certainly some youth will apply to themselves labels that change later, and again, so that's why we have to kind of constantly be reassessing, and I think that by applying a label, seeing how it works, and seeing whether it persists, I think that can be a really important developmental process for youth, and so absolutely those can change, and I think that's part of the exciting care that we provide.
Awesome. So unfortunately, that's all the time we have for the Q&A session today, and just the attendees whose questions weren't answered, I will get back to you guys via email, and we'll make sure to respond to your questions in a timely way. So I want to thank, again, both Scott and Abigail for today's presentation, which is really excellent, and thank all of our participants for staying on and having such an engaging Q&A session. As a reminder, the slides will be available to download on the page that pops up when you exit today's session, and additionally on that page there's an evaluation which we'd really love your feedback on. And that the evaluation is required if you're looking to get CME or CEU credit for this session. So that'll officially conclude today's webinar. Thanks on behalf of the School-Based Health Alliance and the Education Center so much for your participation, and have a great afternoon.